So our panelists, we have three incredible panelists. First is Dr. Rory Spiegel. Dr. Spiegel is our resident art school dropout, as you may or may not know, who's an emergency physician and surgical intensivist at Washington Hospital Center. He's also the director of critical care education for MEP. Dr. Suzanne Simkovich, I just recently learned, was a former tax accountant. Didn't realize that, but very helpful this time of year. She's a pulmonologist and an intensivist at Georgetown. She's also now the interim director at Southern Maryland, and importantly spends half of her time as an implementation scientist and health outcomes researcher at MHRI. And Stephanie Chamberlain, your friendly neighborhood seasoned ICU nurse, seasoned is her word, not mine, who is graduating in 25 days with a doctorate as a critical care clinical nurse specialist. So welcome to the panelists, welcome to all of our guests. Let's just go ahead and jump in because there's lots to discuss. And Suzanne, I'm going to start with you. Vasoactive medications have traditionally been administered through central venous catheters, and I wonder if you could just start by talking about that.
So as long as I've been a doctor, so I graduated in 2013. I have only seen central venous catheters being used to administer vasoactive medications. And when you look back through the history, that has been the dogma, and back into the 50s and 60s, that we need to use larger, more sturdy catheters to be able to administer vasoactive medications. And what is it about the vasoactive medications that make us use larger, more sturdy catheters? Well, the thought behind this is that these medications are considered vesicant, meaning they can cause chemical burns, they can cause extravasations that can damage tissue in different ways. And that if we used a central catheter, this risk of extravasation goes away compared to if we use an IV that we would use for many other medications. What's super interesting about this, though, is we've traditionally always used vasoactive medications through a central venous catheter, but there's a number of other vesicant medications that we use routinely through a peripheral catheter without even thinking twice about it. And so this dogma has been existing for a while. And in reviewing the literature over the past 15 years, people have been thinking about, hey, can we use peripheral IVs? They're simpler to be used. And could they be used for vasoactive medications? There's been a number of different studies about this. Small, they're all observational. There's two bigger ones we're going to talk about a little bit later. But this is all theoretic, that we could cause an extravasation and somebody could lose an extremity or have significant tissue damage. There's not really any true documentation besides small case series in the literature about this. So that has led to this idea that should we be using peripheral catheters or midline catheters to administer vasoactive medications? And this is definitely something that's advancing across the country. More and more studies are going this way. I talked to my colleagues about it, and it's happening. And we're already doing it, particularly at MedStar. So why don't we make this more formal and actually talk about the fact that we're doing this?
Yeah, great start, Suzanne. And I would just add to that, I think it's human nature for us to remember and emphasize the risks that we see and not the ones that we don't see. And when you think about it from a patient perspective, and we think about the complications from a central venous catheter, we obviously look a lot at CLABSI because it's a reportable measure. But from a patient perspective, they care about all of the different complications they might be exposed to. And we looked back at our own data from Washington Hospital Center in Georgetown and published a paper several years ago trying to quantify the risk to patients for every central line place, meaning all of those different complications that one might experience, and present it as a number, a rate that we can present. And the number that I want you to hold on to is 1 in 17. That is 1 in 17 central venous catheters that we placed at MedStar was associated with a complication. That could have been CLABSI, it could have also been an arterial injury or a DVT or a pneumothorax, but 1 in 17 that we place had a complication, which is a really a high number. And I think an important number for us to keep in the background when we talk about any potential complications that may come from something like peripheral pressors. And we this group, Suzanne, Rory, Stephanie, led a really impressive pilot of the implementation of peripheral pressors. Rory, I wonder if I can transition to you to have you discuss that.
Yeah, sure. I just want to quickly, as the slides are loading, piggyback off everything that was said so far. I think when we talk about peripheral pressors, or talk about pressors in general, it's often talked about in absolute terms. They must be run through a central line. They can't be run through a peripheral line. And really what we're talking about is risk profiles, right? There are risks to running pressors through peripheral lines, and there are risks to put central lines in. And what you're doing when you decide to run pressors peripherally is balancing the risks of the pressors run peripheral versus balancing the risks of the central line. And if you can select the right patient that have a very good risk profile for peripheral pressors, we feel that the risk of central line is outweighs the risks of running your pressors peripherally. So what we did was essentially ran a pilot testing this very thing at a hospital center. It ran for 3 months throughout all our ICUs, and we'll talk about patient selection in a little bit as we go over picking the right patient for peripheral pressors shortly. But overall, we enrolled 219 patients. If you look, the majority of these patients in our pilot were through a peripheral line and very few through midline. That was just the culture at a hospital center, which again, I think we'll speak about in a little bit, we're hoping to change. The median dose was 10.5 and the median time was about 18 hours. Now that varied widely. There was people who just had pressors on for a few hours, and there was people that actually went all the way out to 5 days. Specific cases like palliative care cases, or moving towards comfort care, or MAP pushes in specific neuro cases. But overall, it stayed under 24 hours. If you look, out of the whole group, only about 20% of them went on to need a central line at all, showing that you can drastically reduce the amount of central lines you place if you have a peripheral pressor program that's dedicated to running these pressors safely. The other thing we found with looking at severe complications, we essentially had 0. And what we defined as severe complication was an extravasation requiring intervention or cardiac arrest due to loss of IV access in a pressor-dependent patient. And again, we found none of those in our patient population.
Okay. Suzanne, I'm going to come back to you. So if we weren't going to place a central venous catheter, we talk about midlines, we talk about peripheral catheters. Can you talk a little bit about start with peripheral catheters, maybe the how-to?
So let's talk a little bit of, I think what we should start with, Manish, is let's talk about what we know so far about peripheral catheters. And what we have seen so far is there have been very few studies done on this with any significant numbers of patients. And can you guys see my screen? Just want to make sure. And so this has led that people think they're safe. There's been a number of published studies in journals with maybe 30, 40 patients, but there's really only been 2 larger studies, and they're all retrospective and observational around the use of peripheral vasopressors. I wanted to talk about both of these because I think this has led to some of our conclusions that we can call this safe and have led to our adoption here at MedStar. The first one is the most recent one, which is Yerke et al. It was actually done at Cleveland Clinic. It's actually in a quaternary medical center in their medical ICU. This included 635 patients, and they ran pressors peripherally, only used norepinephrine. Their median dose was 10 micrograms per minute. Their median length of use was 5.8 hours, but they're like ours, not quite up to 5 days, but 2 to 19.7 hours was their range. And their primary outcome from this study was the median number of days of CVC days avoided per patient. And they came up with 1. Now, how was this number calculated, which was really my big question when I read this study. And there's a group called the National Healthcare Safety Network, which is the definition that we use to calculate CLABSIs, for example, is where you may have heard about this before. And they have a definition of how you calculate your number of CVC days or central venous catheter days. But I think that's beyond the topic of the conversation, but it does give us some perspective on that they were able to show that 1 day per patient of central line use was avoided. And they had 51.6% of their patients not receive central lines. Remember, this is a medical ICU population. The population we did in our pilot at Hospital Center did include the surgical, neuro, and ER, and the cardiac ICUs. They had 35 patients with extravasations, 5.5% incidence, and these were all non-severe. And one of the interesting things about this study was they looked at patients who extended the use of peripheral pressors beyond 24 hours. And most studies and in our guidelines we're adopting at MedStar are to only use these for 24 hours. 3.9% higher rate of extravasation in those who received them for greater than 24 hours. And also notably is that 55.1% of patients who are receiving them broke off from their policy at some point. This is similar to what we actually calculated when we looked at our population at Hospital Center. We found about between 60 and 70% did not meet criteria for some point. And what that means is, did they go over the maximum dose? Did they go over the maximum length of use? Did they need 2 pressors at some point? So this is the most recent study, but remember this is single center and only in the medical ICU. The one prior to this that has driven a lot of the work in this area was a study done at an academic community hospital in Long Island with 734 patients, where they had a selection of patients with and used norepi, dopamine, and phenylephrine. Their median use, though, interestingly, was 49 hours plus or minus 22 hours. So they tried a significantly longer period of time. They didn't give us much sub-analysis in this paper. It's not very detailed, and their extravasation rate was 13.1% in all minor. So with these being the 2 big papers that we're looking at for this, it showed us that peripheral vasopressors are safe. If we're looking at a 13.1% extravasation rate, it's fair, and they're all minor. That's fairly low. We had 0 serious injuries in our population at Hospital Center. We had 3 very minor ones that required phentolamine and removal of the IV. And so that has led to the fact that we should be using these in our risk-benefit profile and to be considered to be using them.
Yes, Suzanne, those are interesting data. And if we go back to what Rory was presenting earlier, Rory, if I saw the numbers correctly, it's almost 80% of individuals who had peripheral pressors started never got a central line in our data. And just if we believe our data from the past, that would suggest that 10 of our patients did not experience a complication that they would have otherwise potentially been exposed to from having a central venous catheter placed. And Suzanne, one of the points that I think I'm hearing you make is that while we look at extravasation as an event that is fearful and we don't want to happen, almost all the extravasations that I hear you describe were minor events. Is that right?
They are minor. There was no serious events described in either paper. There was no issues with needing surgical debridement. There was no issue. They were all minor, used phentolamine to treat or heat compresses.
And this is in comparison to pretty good data that we have that suggests every eclampsia extends hospital length of stay, extends cost, increases mortality, DVT, PE. We know the risks of that in terms of anticoagulation and pneumothorax, a patient having to get a chest tube potentially. So very real complications from central venous catheters placed. Rory, I wonder if we can talk about.
Well, let me mention one more thing also important, Manish, is that the surviving sepsis guidelines in 2021 are endorsing the use of peripheral vasopressors, but at a low recommendation because of the lack of data.
Yeah, and hopefully a place that we can contribute. Rory, let's talk a little bit more about midlines. Why might we choose those over peripheral pressors? And I would say, before we've had a lot of our conversations, I didn't know a lot about midlines. I wonder if you can talk about them.
Yeah, I think that's great. Briefly on the peripheral lines, I think just to piggyback off what was said so far, it's the concept of picking the right line and the right patient. As this data kind of suggests, there will be extravasation events. Honestly, we saw less extravasation events than what's in the published literature. That could just be random sampling error. But it could be because of the profile or the policy we've made and the way we've developed our profile, which is essentially ensuring you're picking an appropriate line that's safe, ensuring that you have a policy that makes sure people are watching that line. So if it does extravasate, it's stopped very early, and then ensuring the dose of medication you're giving is low enough that if you do extravasate, there's not enough time for anyone to have, right? And those are the real three factors you want to consider when you're selecting a patient for peripheral pressors. As far as the lines, we can start first with peripheral lines. Essentially, the simple part is it's got to be a 20 gauge or higher in the forearm, right? As you get down into the wrist and the hand, or up into the anticube or upper arm, the risk of extravasation becomes higher, right? And you're always balancing risk benefit. No one's saying never do that in an emergent situation. If you have to run pressors, run them through whatever line you have to. But when you're considering long-term use of those pressors, as you get into the wrist or up into the upper arm or the anticube, the risk just gets too high to say it's useful. So forearm for peripheral pressors. Where midlines come in, I think, is a number of things. One, a midline is a catheter that's between 8 and 20 centimeters long that you essentially are placing in the deep vessels of the upper arm, but it doesn't reach the central circulation. So on the outside, it looks a little bit like a PIC, but it won't actually cross into central circulation. The big advantage of that is the infection rate is incredibly low compared to a PIC. Now, the big advantage over a peripheral line is it's just a much more robust line. Because of its length, it travels much farther into the vessel. And this gives you a couple things. One, the chance of dislodgement becomes extremely rare, right? Moving it won't simply pull it out of the vessel, because with a peripheral catheter, you have half a centimeter sitting in the vessel at best of times, right? The other thing is, a lot of times when we're putting in peripheral lines, especially when you're using ultrasound and they're somewhat deeper, you tend to go at a steep angle, and you tend to actually injure the back wall of the vessel where you've inserted the line. And again, with a peripheral line, now that's sitting right by where the injured vessel is, and you increase the rate of extravasation, where with a midline, you've put that catheter way up the vessel. And so extravasation rates are incredibly low. And so this gives you a number of advantages, mostly just the robustness and I think the safety of running pressors through them. If you look at how midlines fail in the data, they don't extravasate. They essentially stop working after 48 hours to a month, depending on the line, right? And so most of the time what happens with these lines is you just can't use them after a while. But they're not going to extravasate once it is. When you look at the few published cases of extravasation of a midline, it becomes quite clear it didn't extravasate. They just didn't put the line in the first place. So what you see is someone thinks they have the midline in, they get some blood back, but it's kind of weak blood return after placing the line. And that usually is you poke, you've created a little hematoma, and so you can pull back on it. And then they start infusing whatever they're going to infuse. And because the line is rather deep, you don't notice it extravasating at first, but after a while, it becomes clear that the line extravasated immediately. And so as long as you ensure safety from the standpoint of confirming placement to begin with, and what I mean by that is make sure the line's in, make sure you have good blood returns, but most notably do a bubble study, which is essentially get the echo that you used or the ultrasound that you used to place the line, put it on the heart, get a good view of the right ventricle, and just push one flush through it, and you'll see bubbles light up the right ventricle, confirming that you're in. Once you've done that, you have a very robust line that is much lower risk of extravasation. And so in my mind, and what we're hoping to show over time, is a much safer line to run pressors through. Now that data, the actual data on pressors through midlines, is not as robust as we'd like it. There's essentially 2 studies in the literature totaling about 400 patients. Very good results. Again, no extravasation events that were of any notable case. And again, most of these lines failed at somewhere between a week and 3 weeks because they just stopped working over time. So when you're thinking about running pressors and when you're thinking about selecting a midline, I think the big things is, one, they just don't have appropriate peripheral access from a peripheral line standpoint. And two, maybe it's a patient that you want to run pressors for a little longer. In our policy, we say about 24 hours for peripheral lines. But when you have a midline in, it can go up to 72 hours simply because it's a far more robust line that you're running.
And Rory, let me offer just a couple pieces of context, because I suspect many people on the call have never placed a midline, myself included. Those catheters, I think, are 8 to 10 centimeters. Is that right?
Depends on the kit you're using. The lowest is 8 centimeters. They actually go up to about 20 centimeters. So there's customizable kits that you can cut the catheter to the size that you want. I think for most of us, and when we're talking about placing midlines, those are probably too complicated. There's a lot of built-in kits that you essentially, the whole midline, it has a wire in catheter kit that comes as one whole thing, and it's almost like placing an arrow arterial line as you slide the wire and then slide the catheter over it. And those come in either 8 or 10 centimeter catheters usually.
Okay. The other pieces I was thinking about, just this idea of peripheral pressors. Like, as an emergency physician, I run peripheral pressors weekly, I would say, right? And I think it's an important context of, we're not talking about that acute phase resuscitation when a patient comes into the ED. We're all going to continue to keep doing that, and we're going to do that because it's the right thing to do for patients in that acute phase, while you're getting IV access, while you're figuring out what's going on, while you're starting volume resuscitation, all the other things you need to do. But this conversation is more on the back end of that resuscitation, when you're deciding, what direction am I going into this patient? Are they going to continue to need, or is there some degree of uncertainty on if they're going to need to be on pressors for a longer period of time, and that lower dose of pressors is, again, what I'm hearing you say. So I don't think any of us are saying we're altering that acute phase of resuscitation. We'll continue to do peripheral pressors in those individuals. My last quick comment is, I think we need to rebrand bubble study, because I think if you say that, people are going to just turn off. I think we just need to say, we need to confirm placement with a flush, with an echo. But anyways, I wonder if we could talk a little bit more about risk profile, if now is the right time. Stephanie, I also want to hear your opinions on things, but Rory, you want to go to risk profile?
Yeah, we can put in risk profile. As far as running pressors peripherally in the resuscitation phase, there's a key point that the first line of our policy says you can run any amount of pressors through any line that you need to resuscitate a patient, right? Like, this has nothing to do with that. It's on the back end, like you said, when you're deciding which patients are appropriate and safe to run pressors peripherally. And again, this is a risk-benefit analysis you're doing, the risk of central lines versus the risk of running pressors peripherally. And the hope here is that we can develop a reasonable profile of patients that we think are appropriate for peripheral pressors. So we've developed this peripheral vasoactive risk profile score. To be upfront, this is not data. This is not published data that we have a published score. Essentially, what we're doing here is trying to translate our CPG into an easily understandable infographic that you can kind of use at the bedside as a tool to decide not only who would actually benefit from peripheral pressors, but also kind of risk stratify your workflow. How quickly do you have to put this central line in? Like, if you're in the emergency department and the waiting room is packed, you're already 25 patients deep, does this patient need the central line now, or can they wait till they go up to the ICU, right? And so just to help with your workflow and where to prioritize centralized placement in the ones that don't meet criteria for peripheral pressors. So it's fairly simple. You score 0, 1, or 2. And if you look on the right side, you have risk factors. And each one of these risk factors gives you 1 additional point. Essentially, if you have 0 points, you have a patient that's appropriate for the peripheral pressor policy, and pressors can be run over a long period of time. When you're in that 1 point group, these are the intermediate risk. These are the ones that will likely need a central line over the next 6 hours or so. But if you think it's very early in the resuscitation and you can kind of get them off pressors or get their pressor dose low by antibiotics, fluid, or resuscitation or so on, or if you think, well, I don't quite have the access I need at this point, but I can place a midline, and now all of a sudden they go from low or intermediate risk back to low risk, you can kind of shift those middle group. The high risk patients, these are the ones where the risk of extravasation is probably beyond the level which is comfortable to run pressors over any really long period of time. And these are the ones we feel should be prioritized to have central lines placed as soon as you can. And so I think this is a nice model that allows you to quickly identify who meets the kind of criteria for peripheral pressors, but also helps you risk stratify what to do with the patients who don't quite meet those criteria yet.
Yeah, that's great. Like you said, this is translating kind of the policy into an infographic that helps as a discussion tool and as kind of a tool as you're going through the thought process. Stephanie, so many nursing related issues. I wonder if we can pivot to you to discuss some of them.
Yeah, definitely. Thanks. I should have added into the front. I do work at Washington Hospital Center with Rory and then closely with Suzanne as well. So I think I'm frozen on the screen. Hopefully it'll come back. One of the things we did when we were rolling this out, and this came out of Suzanne's very hard and in-depth work, was we did some pre-intervention studies of perceptions of these vasoactive meds going peripherally. And one of the things I obviously really focused on the nursing aspect of it, and it's really shook out. And then in conversations that I had with nurses in the facility and I can say this as an old experienced nurses versus the very young nurses. And the very young nurses their fears were, I don't know what to do essentially if something goes wrong, which is their fear about everything, right? That if they don't have enough experiences under their belt, they don't have those pathways built to know what to do necessarily when something goes wrong. So they're worried about assessing anything that could go wrong. And then our more seasoned nurses fell into this bucket of, well, this is the way we've done it. This is the safest thing that could be done. They have a picture of that one grandma in their head who had an extravasation. Maybe it was even potassium. Maybe it was amiodarone. Maybe it was a norepinephrine, but that sticks with them. And so they have that in their brain. So we really had to do a lot of changing of hearts and minds to get people engaged in this process and show them that it was possible to safely do. And that's one of the things that we really went forth with in the nursing side of things, was that this whole guideline was built specifically for safety. It is to put guardrails around some things that either you already were doing or are going to be a higher risk undertaking, and you want to make sure that you're doing it safely. So we made this order set to go along with our CPG. It's called Vasopressors for Peripheral Administration. It has inclusion and exclusion criteria at the very top. So when a physician is putting that order in and they see, oh, whoops, we don't meet it because, they are down a limb due to a DVT, or they are, we know we're starting two pressors, whatever inclusion or exclusion criteria may exist, so that they could potentially then push off and go straight to central, or know that, okay, we've knocked out the big scaries and we can continue to safely move forward with this. And then, like Rory mentioned, the IV sizes, the anatomical locations, that is in that order set as well, just to remind the nurses, hey, if someone is suggesting we do this, we need to have a line in the right anatomical geographic location on this patient to do it safely. It also, the order set has, and the reason I'm focusing on the order set is because both experienced and unexperienced nurses will always look through an order set, especially a new one, to determine if they are doing everything the way they should. So it has great reminders in it, just some things that you would think as someone who's been around for a while, someone should know this, but just again, in our post-COVID world, we have a lot of inexperienced nurses. So don't put that BP cuff on the same arm. Don't hide that IV site under a blanket so that it potentially couldn't get seen for an hour, not under a pillow. You want that within your visual field at all times. We felt strongly that we didn't want to add documentation burden to the nurse for this. So we didn't want them to have to document an assessment on it more than Q4 hours, which is sort of the standard full body assessment on an ICU patient. So we wanted a visual monitoring of it for signs and symptoms. It even goes into signs and symptoms in the order set, and then doing that documentation every 4 hours. The order set also gives you leeway in the dosing that we have that says you can go, much like Rory said earlier, you can go higher in emergent situations. This is not at any instance telling you to say as the nurse, no, I can't go higher than this because it's outside of my order, but that you should have a conversation about it. Hey, Manish, this patient's getting sicker. We are going above, I'm at 19 of norepi, and I'm afraid like they've stopped peeing as well. Things are potentially going sideways. We may need to consider a central line now. But at the same time, you are, still protected with that in an emergent situation. What we said with the nurses is that this frequent assessment is key. Finding, watching that line and making sure that it is continuing to look nice, that you don't see any signs and symptoms of extravasation, are very important. A little story about the rollout. We have been able to successfully say that no one in our protocol has had a dangerous safety event with extravasations. I will say that early on there were, and laughing I can tell you now, Rory and Suzanne and I became responsible for every extravasation that happened at Washington Hospital Center, whether it was related to this process and protocol at all. So there were times where someone would have peripheral vasopressors running, and it seemed like there was a thought in people's head where they thought, okay, we can run this now. But what wasn't followed through with that on that thought process was, do you fall within the guidelines of this practice? So we did have a serious safety event in our medical ICU that did require surgical debridement, but she had a very small IV in her upper arm for an extended amount of time with large high doses of norepinephrine running, with no peripheral vasopressor order set in sight, no understanding that was necessary, and that the assessments associated that was necessary. But what do? We try and improve after that, so that nursing division and department, they did a PDSA cycle after it and decided what they wanted to do was add even additional awareness. It's on their resource sheets now, and they also have a purple sheet that they've added to the door so it can even guide rounds. It says, this is where the IV is located. This is the medication that's running through it. This is when it started. This is when our tentative time to be off versus time to potentially get a central line needed to be met. So I see Rory's pulling that up. Yep. So before I move on to extravasations, let's see, Rory. Yep. Thank you for pulling that up. That's the purple sheet that they use. So we're hoping that we'll be rolling this out everywhere else as well in hospital centers, ICUs, just because then, the nurse can say like, look, this is when we initiated this, or, and also so it can guide discussions within the interdisciplinary team, and then it can also just be a visual reminder to everybody that, oh yeah, this person does have peripheral vasopressors running, and we need to be extra focused on that IV site assessment.
Steph, can I chime in on just piggyback?
Yeah, please.
That? Yeah, I think one of the big things you realize when you're on every email about every extravasation that happens with peripheral lines is awareness is key. If you look at these events, they always happen in the same way. Is either the clinician who was starting to run pressors through a peripheral line never looked at the line, because they, if they had, they would have like, oh wait, you can't run pressors through, a 22 in the finger. Or there was loss of oversight of awareness that the patient was getting pressors through a peripheral line later on. So they started pressors peripherally, and then no one paid attention to them for a while. And so the big things to run pressors peripherally is line selection, patient selection, and make sure you can see the line. And so one of the things, not only do we want to run pressors peripherally, and we want to do it safely, one of the big things that came out of this is happening, right? We're running pressors peripherally all the time, whether we have a policy or not. And so how do we do it safely? And so part of this is to enable us not to place central lines if patients don't need them, but it's also to be like, hey, no, this patient doesn't meet criteria and you're getting into a pretty high risk situation, and it's this, and this, these are the reasons why you shouldn't be running them. And if you can fix some of those, yeah, maybe you can do it. But if you can't, that patient needs a central line.
One of the things that Rory would reiterate to me a lot, and it's kind of stuck with my head too, is that, and it's kind of leading me into the extravasation discussion, is that usually when your patient with peripheral vasopressors running, if you have a bump up of sudden needs of your pressor, it's instead of your patient swooning or getting sicker suddenly, it's probably because you lost your line and you didn't realize it. And that's one of the things that we're reminding people too, is like if your pressure is falling and you're starting to go up on your pressor, the first thing you should do is assess that site. Did you extravasate? Is that the problem versus your patient is, swooning really badly and getting pretty sick? So for extravasations, many of you probably know that there is an order set and a job aid that's just gone really widely live called the non-cytotoxic extravasation adult order set. That is a mouthful. But what it does have in it is a decision tree that includes vasoactive therapies with heat and warm therapy, extravasation management, and the phentolamine order, with directions as to how to do that clockwise wheel around it, which can be done by the RN. That's something I've been asked a lot. It also has a job aid with a QR code on it that shows you how to inject all around. Also, maybe everybody on this call knows this, but I like to reiterate it just to be sure. Lots of people assume you should just take the catheter out straight away if you've extravasated, but instead you're supposed to aspirate out as much as you can and then give some phentolamine straight through that catheter before you remove it, so that you can sort of feed that track with the phentolamine to help with any tissue loss there. And another thing that we're telling people is that extravasation doesn't automatically mean failure. It doesn't mean they failed this pilot. You may be able to get them through, and you were able to delay for a while so you could diagnose, treat. Maybe you were able to give fluids, you were able to give antibiotics and turn them around before something terrible occurred. So we're trying to get people to move away from the idea of thinking of equating extravasation with failure. So I put that non-cytotoxic extravasation adult order set in your brain because that is the order set that has to be ordered a lot of times in the middle of the night. If you have, if your attending is not around, if you have a resident, they might not know they need to order that, and they may just order phentolamine on its own, but it does come with other assessments and other orders that go along with it. So if you can use that order set, it's best.
Stephanie, so many great points. I think some of the points that I heard, this is happening, peripheral pressor use is happening kind of regardless. And I think part of this initiative is making the entire process safer, which is huge. I mean, to be able to say that all of the patients that met the criteria, none of them had a serious extravasation, is pretty remarkable. And I think that speaks to all of the forethought that the three of you did and many others that were involved in rolling this out, particularly the nurse monitoring aspect. And so I want to, there's two questions, there's three now questions in the chat, and I want to just kind of go through those one by one. Suzanne, I wonder if you can address Alex's question about the decision-making process, risk benefits when removing a central line for a patient who's still on low-dose pressors.
So I think that's a really good point, Alex, about removing the central line. It's actually something we did not have an in-depth conversation about when we put together this CPG, and we're hoping that in later iterations of this that we could address that as more data comes out on this. About removing a central line when someone's on low dose pressors. One of the ways I think about that is we have a patient who's had some shock, they're on and off probably 1 to 4 of levo for a couple of days, they may on and off. And one of the things the article from Cardenas Garcia in 2015 addressed is 10% of their population that used peripheral vasopressors was after a central line placed, and they used it to remove the central line. And they did not have an increased rate of complications with that population. So it's definitely something I think we should consider doing in our patients and could help us with removing central lines. Although a lot of the complications we talk about occur with placement, we're also talking about CLABSIs and vascular damage to having a central line in place and from it remaining in place for a long time. The other thing we did talk about was comfort care. And should that be an exception? Because I think a lot of us would feel very uncomfortable putting a central line in a patient who needs a little bit of pressor for a few days while they're waiting for their kids to get in from far away or something along those circumstances. And it's not directly addressed in the CPG other than if there's circumstances of comfort care, we should consider the risks and benefits of each procedure. And I personally would practice on continuing the peripheral vasopressors as long as they're within a safe dose that would not cause more pain and suffering to the patient while we're trying to get them to the end of their life with their family.
So one of the things I would add to that is this idea that you continue to do kind of risk profiles daily on patients. The CPG itself says it's a recommended a 24-hour period for peripheral lines and 72 for midlines, but it actually says that the attending clinician can extend that as long as they have a clinical reason to do so. And so I like to think about that as as you daily assess the risk benefit of like diuresis on a patient or ongoing use of a central line, you're kind of reassessing the risk benefit of peripheral pressors as well. Again, I think the complications come when you lose awareness of it, not when you're, if you're looking at a peripheral line, you still think the integrity of that peripheral line is good. You're still on low dose pressors and you still think it's appropriate because you think this patient has an endpoint where you'll get them more pressors shortly. It's not appropriate to extend the use of peripheral pressors longer. The same could be said when you're trying to take out a central line. If someone's on low dose pressors and you think you can get them off within a few days, then switching to a peripheral line is, I feel, is totally appropriate. Understanding you might have to kind of extend those peripheral pressors past the 24-hour period as long as you're continuing to assess that risk benefit.
To that point, can you address Kevin's question?
As far as confirming line placement?
Yeah, and daily ultrasounds.
Yeah, I mean, so we stayed away from daily ultrasounds on patients because it's just a lot of work to require people to do daily ultrasounds. I think the bubble study, or as Manish liked to say, the flush study, I think is your friend anytime you want to make sure any line is in an appropriate place. And so my personal practice is in patients who are obese and you're worried about the integrity of your peripheral lines is to move towards a midline. Because again, the stability of a midline is far better than the stabilities of peripheral line, especially people that are getting edematous and you're concerned about the safety of or the integrity of that line. We really, in our protocol, really relied on the bedside nurse's abilities to assess peripheral lines. And this was mostly done with the work of Stephanie and the rest of the group, who really felt strongly that our bedside intensive care critical care nurses are really good at assessing lines, and we should use their skills to do so. At any point in the CPG, if someone doesn't think a line is actually in the right place or concerned about integrity, it is recommended to use ultrasound to do a bubble flush study, but it's not a mandatory thing in every patient to do it daily.
Kevin?
The issue, and I think the consternation that many nurses in the ICU have felt about this policy is that they, as you said, they are the ones that are the experts in evaluating these lines, but their concerns have been put down when they say, I don't think that this line is appropriate. The effort to get a midline placed is hampered by the fact that there's only a few people within the hospital that can place a midline because the IV therapy team cannot. So for these patients, if the hospital would revamp its ability to train nurses to use the ultrasound to place IVs, they could then use the ultrasound to evaluate those IVs on their own, those peripheral IVs. But as it stands now, most nurses are not able to use the ultrasound to evaluate an IV. And in these patients with larger arms who don't have good vasculature, that has been one of the main sticking points is this a good IV? Oftentimes nurses are saying, I don't have a good way to evaluate this IV because the tissue around it is too edematous or whatever. And that I think that this would go a long way towards continuing to support this program, and also giving some sort of clear evaluation of the health of the line. And I don't know how to put my hand down. I'm trying, but if somebody can put my hand down for me.
I take care. Thanks for the comment. Rory, go ahead.
I would say all your points are totally valid. I often say we ignore, our nurses' assessment at our own peril, right? Like this, the safety of this protocol is built around the bedside nurse and their ability to assess the lines. I would never use a peripheral line that the nurse doesn't feel comfortable with, because that's how we ensure safety. Part of that sounds like we just need to do more education with our providers, and it's this kind of pop-up that's going down. The other part is, to your point about placing midlines, we are now starting a midline training program to get our providers, or most of our providers, comfortable with placing midlines. It's starting with a small pilot at Georgetown, but then should be quickly moving to hospital center and throughout the system, where we should be able to train our providers to be far more proficient in placing midlines to address these patients that we don't feel comfortable with the peripheral lines. One of the things we're adding to that is we hope to do a small pilot with nurses placing these lines as well. That one, we've got a little more work to do, but to even increase the comfort with the ability to place these lines in these patients.
And Rory, I want to talk about that with the rollout, but before we get to that, can we just take a look at Megan's question? And Suzanne, would you be comfortable answering that one, about when to give phentolamine?
I'm going to defer a lot to Stephanie on this, since she does most of the wound care, if that's okay, on these types of when she would give it as the nurse expert here.
Yeah, I mean, the order set has your signs and symptoms. It's not subtle when this happens, and you're also not going to hurt anyone with phentolamine. So in this instance, what you want to do is you're going to see swelling, you're going to see redness, it's going to look like it's sort of spreading out from the site, sort of a little bit like a puncture wound would, or like sort of like a hematoma around a puncture wound. If the patient can tell you anything, they're going to have soreness, they're going to have itching. So any of those symptoms can kick off the need for phentolamine placement. So I would say err on the side of caution. Don't wait it out, because if you wait it out, and then the longer you wait to give phentolamine, the more the wound will have bloomed and worsened before you're able to intervene, sorry.
And also to add on that, Stephanie, is that the peripheral vasopressor order set is going to have phentolamine already available, so that although I think it's always important that the physician or APP know that it was given, it will be available for nurses to rapidly give it, so they're not waiting for an order to do so if there is an extravasation.
Great. So, Rory, I'm going to come back to you to discuss the rollout. And when you're doing so, if you can include the conversation about double lumen midlines.
Yeah, to bring up double lumen midlines at first, obviously you can get midlines that both are single lumen and double lumen. Most of your double lumen midlines are the 20 centimeter cuttable midlines that you have to adjust to the patient. So they're slightly more complicated and tenuous to put in. I'm not sure they really give you anything advantageous. The idea of a double lumen central line is you can run two drugs that are non-compatible side to side, and because you're going to a central vein, it doesn't really matter. Remember, a midline is only 10 centimeters, and you're putting it to a small vein in the arm, so you're still not able to really run generally two things that are uncompatible. So you can split your line up a little higher if you want to run two things that are compatible anyway, and a double lumen midline just makes each actual catheter smaller, right? And so for the most part, like we will have the options of having double lumen midlines and single lumen midlines at most of our sites. That really depended on the site, but most of the training we're going to be doing are in the simple single lumen 8 to 10 centimeter midlines that are self-contained, because we think it'll probably give us the most amount of people that we can train to become proficient in this line versus, you know, the options you have to place the lens. All right, so as far as rollout, let me just move a slide. So we're doing something rather unique with the peripheral pressor rollout. Most of the time, once something is approved, it kind of just goes live throughout the whole system, and we just say good luck and we start. What we wanted to do was actually create like a model of how we should roll out these big protocols in critical care, both from like a quality and safety standpoint, so we can like actually investigate the safety of them rolling out, but also so we can collect data that we can use on the quality and safety and the science of what happens when you start implementing these things through the system. So we're doing a staggered release. This is a tenuous schedule. Obviously, the dates may shift slightly dependent on nursing education capacity as well as IT capacity from our order set that has to go live at each site prior to rolling it out. But the idea here is we have intensive rollout and a standard rollout. I'll let Suzanne talk a little more about the intensive rollout because that's her baby. But essentially, we're going to stagger these over different months, and so we can look at outcomes before and after the initiation of the protocol at each of these sites and give ourselves some data on the safety and efficacy of it.
So thanks, Rory. So one of the things that, as we're a system, we have a bunch of diverse hospitals across our system, and there's not a one-size-fits-all approach to rolling out a protocol. And one of the things we do know from reviewing the literature and our experience at MedStar is that uptake of protocols is largely not good. We don't do evidence-based practice well. And this isn't a criticism of MedStar. This is a criticism of the critical care community as a whole. There's been two recent papers about low tidal volume ventilation that came out that showed somewhat very negative use of and low uptake of a very well validated study. And this is one of the few things that there's actually data for. So one of the things that Rory and I would like to do is consider how can we increase uptake and improve patient safety of protocols. So what we want to try is a strategy of what we're calling intensive rollout, where we try to meet each protocol's needs of the hospital. We know that with our diverse hospitals, we need to have some customization to each hospital, and a protocol coming out at the system level is not going to meet each hospital's needs. So we are selecting Southern Maryland and Georgetown to get an intensive rollout protocol for this, where we are first going to be asking our nurses and APPs and physicians their knowledge and attitudes about the use of peripheral vasopressors. We're then going to go from there and adjust the protocol, keeping the essence of it, but maybe there's some specific caveats we need to put in there to make the protocol work for the site. Maybe there's more patients that need, for example, at Georgetown, there's more patients that are transplant patients, they're cirrhotic, their physiology is different. So maybe we need to adjust to their needs. And also adjust the education protocol so that it meets the needs of the facility and addresses all the concerns. We're then going to implement our protocol, and we're going to follow our outcomes to see how compliant people are with the protocol, how many central lines we're avoiding, a number of exploratory outcomes. We're not setting this up as a trial with definitive outcomes, as we'd like to see how this performs. And then we're going to have our other sites do a standard rollout, and we want to see how is uptake compare at the different sites. When we look at Southern Maryland and Georgetown compared to a standard rollout protocol. And can this be a model for going forward? We might not get it right the first time, and we're willing to accept that, but it can give us some feedback as to maybe there's a different way we should be rolling these protocols out that have significant safety implications.
And Suzanne, if I can just comment on that, it's really taking advantage of having embedded research scientists like yourself that kind of play two roles, and then MedStar's size and scope in allowing us to implement things in a thoughtful way that allow us to learn, and then also create knowledge that's somewhat generalizable, just given how big of a system we are. So I really appreciate the approach that this group is taking to rolling out. I wonder, Stephanie, Joan put an important comment in the chat. Can you address that? You're muted.
Yes. INS, for the physicians in the room, it stands for Infusion Nurses Society. They have been around for a very long time, and they're the go-to for what is current practice in any infusions of peripheral lines. These are the people who place PICC lines, and they often place midlines. We know sort of in the sort of background discussions that they are having a battle back and forth between some people who want to stick with the way we've always done it. We've heard a lot about that regarding the use of vasoactive medications through midlines, and but they have not yet changed their official stance on that. We know they've been battling about it for 2 years as an organization. So until they make a statement saying that nurse-placed midlines are able to utilize peripheral medication, vasoactive medications, the system thought it was important to stick to what would be, if you were in a court of law, what does essentially the governing oversight body say you should do. So that's why we did exclude nurse-placed midlines for this from the pilot.
Thanks, Steph. Rory, you're muted.
The hope is once we collect more data on our midlines that we can demonstrate that, in fact, it is safe. I'm of the opinion, obviously, that I think it's actually a safer line to run through than actually standard peripheral pressors. So the hope is we can extend it to all our midlines, because it's a shame when a patient has a midline in already. You know, it wasn't placed for peripheral pressors, but they happen to have one in. They make it to the ICU, and you're like, oh, I can't run pressors through this midline, even if I bubble study, confirm it's in the right place, do all the right safety events, because it wasn't placed by a clinician. So as we build up the amount of clinicians that can place midlines, and as we build up both the safety profile and a comfort of these midlines, I think we can move towards using all midlines. That just may take some time.
And Rory or Steph, if you can address Jenna's question.
Yeah, I think Jenna, we're going to keep nurses out of it, and even on the VAT teams, it's going to have to be. So Rory, I think, is just starting to initiate training in areas of the physicians placing them, but I would imagine that's going to be something that would have to be determined at each entity. But right now, nurses placing any midlines, even if they're on the VAT team, should not be used for pressors.
We're hoping that'll change maybe in the future as we get more data. So more to come on that. Maybe next year we'll have a different conversation about this.
Great. Lots of great points that were discussed today. Please feel free to include any last minute questions in the chat. And Rory, I wonder if you could just maybe summarize for us. Yeah,
I'm going to pull up a nice summary slide, but as I do, I think like one of the things we really see, the big key points here in like very simple summaries: picking the right patient, the right line, and ensuring you have a system that can look at that line. I've said that a few times, but I really think it's the most important. And one of the things that I think is often missed from a clinician standpoint is just look at the line. Before you start pressors, look at the line. Our profile here, one of the things I really hope to do with it was try to get people to look at the line, and they have to kind of at least know where the line is when they're calculating this risk profile. Because when you see these extravasation events, it's pretty clear that no one looked at that line to beforehand, because it obviously wasn't a line that was really appropriate for pressors. So anytime you're thinking about running peripheral pressors, just go down, look at the patient, look at the line, and make sure you think it's appropriate. But as far as the criteria, in summary, essentially, these are ICU patients. we really have to make sure they have the actual nursing capacity to actually watch these lines safely. Peripheral pressors should be approved by the attending physician, again, just because I really want an experienced clinician looking at the line. They obviously shouldn't require central line, and the expectation is they'll be on pressors for a short amount of time, a day, maybe a little bit more, but that's the kind of concept. As you start having patients that require larger amount of pressors, so more than one, or have less than ideal access, the risk profile gets too high to safely run pressors peripherally for extended periods of time. When you think about the line, it should be greater than 20 centimeters, or sorry, 20 gauge line located in the forearm, not in the wrist, not in the hand, not in the antequib. And if you do have to move outside that area, consider a midline. Midlines placed in the upper arm are safe as well. The time period is 24 hours for peripheral line, 72 hours for midlines. But again, those can be extended as long as the attending clinician has done another risk assessment and assesses the risk benefit of pressors still is in the benefit of running the peripheral.